This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code My DPC Story. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, patients pay their doctor a low monthly membership and, in return, build a lasting relationship with their doctor and have their doctor available at their fingertips.
I believe that primary care should be the fundamental backbone of the healthcare system, and direct primary care brings hope and momentum for change toward a bright future for primary care in our communities. I'm Dr. Catherine Agricola of Altucare Primary Medical Care, and this is my DPC story.
Dr. Agricola completed her bachelor's at Columbia University in New York, where she studied pre-medical sciences and music, before getting her medical degree at Yale School of Medicine in Connecticut. For residency, she completed a combined Med-Peds residency at the University of Rochester, New York, combined internal medicine and pediatrics program. There, she trained with an emphasis in community health and advocacy. She started at Altucare in July of 2019. Welcome to the podcast, Dr. Agricola.
Thank you so much, Marielle. It's a super pleasure to be here, and I really appreciate all of the work you do in highlighting our colleagues' practices across the country for DPC.
Thank you for that. I want to get started with your location. Can you please share with us where are you located and a little bit about the demographics in your area?
Sure. Yeah. So I'm in New York State. New York State is quite large, and people have different ideas of what that means. So if you say you're from New York, they kind of imagine you must live in Manhattan on the Empire State Building. But that's not where I'm currently located. So I'm in a region called Hudson Valley. It is close to New York, about 2 hours away from New York City. And so it's an interesting demographic because it's fairly rural. There's farmland. There's a lot of kind of salt of the earth folks that are born and bred in the Hudson Valley, but it's so close to New York City that you get a lot of commuters. You get a lot of people who maybe lived in the Bronx or Manhattan or Brooklyn and have now decided to move up into sort of quote unquote upstate to raise their families. And so it's a mixture of a variety of different kinds of people from all walks of life. And it's a neat place to live. It has wonderful hiking areas, and it's very beautiful. And it's not as upstate as other people might think of when you get all the way up towards Canada. So it's still close enough to being metropolitan that people go into the city and things.
What's the population like in terms of, is it a lot of older families, younger families, a good mix?
So it really is a good mix. There are some older kind of retirement communities pocketed along all in the Hudson Valley. There is a burgeoning kind of younger community in some of these kind of hip towns that individuals will settle in, in their young 20s or 30s, without children, and a lot of art and a lot of interest, kind of places where people from Brooklyn, for example, might come up, and there's cool museums and things like that. So yeah, it's kind of ranges from age, from really just the young till definitely some older communities as well.
Now, in terms of your medical degree and training, you are a med peds doctor. So can you tell us about your decision to choose med peds over like family medicine or another specialty?
Sure. Yeah. Med peds, I'm so happy to be med peds. I just have such fun times in my training, and I'm happy to always carry the flag of med peds, because not people don't always know about med peds. So med peds is basically a residency training where you complete both the requirements for internal medicine and the requirements for pediatrics in the 4-year span. And I came upon med peds when in medical school. I didn't know it existed, but when I was in medical school doing our rotations, I kind of started to get the sense that in my pediatrics rotation or my internal medicine rotation, some of these residents that I really gravitated towards, or really were starting to feel like were mentors, happened to be med peds. And there was a really strong med peds program, or there is a really strong med peds program at Yale. And so I started to realize that, like, I think I fit in with these people. And I think they think some of these, for whatever reason, there's kind of a je ne sais quoi about it that I was attracted to. And then there was the part of, I really loved pediatrics, I really loved internal medicine, but I kind of felt like that there was sort of this artificial line drawn of somewhere between 18 and 22. There's something magical that happens that now, you transition into one world of medicine to go to another world of medicine. And to me, I really felt like it just made the most sense to be able to take care of the continuum of age. And so med peds lent itself well to that as well. So, and then, in considering family medicine, my personal interest really wasn't in obstetrics, and it wasn't really in the prenatal care or delivery, or even too much of the surgical side of medicine. Although there was a fleeting moment in medical school where I thought maybe I'll be a surgeon, but I think everybody has those fleeting moments. So family medicine, I think there were parts of it, the training, that didn't necessarily fit what I was looking for. And then the med peds training as well, I really liked that it kind of delved deeper into both internal medicine and pediatrics with a little bit more ICU care and critical care, complex medical things, and then had this cool niche of transition medicine, where in most med peds programs, you have time spent thinking or caring for this population of children who had chronic diseases in childhood, like type 1 diabetes, or survivors of childhood cancer or sickle cell disease or something, and really thinking about how do those individuals transition into adulthood and how to make that a special population. And so MedP just kind of called out to me. And then there's the thing about just not being able to decide what you want to do with your life, that med peds is a really good fit for too, where it leaves tons of options open. And so there was times where I thought maybe I would be a subspecialist in, say, critical care or cardiology or something like that. And so med peds kind of left all doors open.
That's wonderful. And, it I am sure has now allowed you to be a very well-rounded and adaptable DPC doctor.
Yeah, it's funny when you have an adult and you see them, you kind of sometimes digress into their childhood, their childhood experiences or illnesses, and you start to connect some dots that may not have been connected otherwise. And then, there's a whole other realm of kind of care that I can get more and more interested as time goes on, is sort of the adverse childhood events and childhood trauma, and understanding that so much of what happens in childhood carries forward into adulthood. And so these things are not siloed. They're very much just this big continuum of a person. So yes, I think med peds and family medicine for that reason are really wonderful specialties.
And what a gift as someone who is full scope trained in the generational sense that you're able to address that with your patients rather than if they bring up childhood issues that equals a referral.
Yes. Yes, I will say being a DBC doc, I do find myself just flexing to referral much less, which is nice.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. How did you end up finding out about DPC? And were there any impacting forces that drove you into DPC versus another type of position?
So, it's funny. I would have to say that DPC kind of found me, that I didn't really find DPC so much as it found me. I finished my residency training and then had spent so much time in my training in academic medicine, both in undergraduate and doing some research actually between medical school or between college and medical school, like basic science bench research, doing some, thesis research during medical school, which was part of our requirement, and then going into a residency program that also was very strong in academics. Kind of consciously choosing to leave academics, partly because of my strong belief in primary care as sort of just such an important thing that most of the people that are being cared for in primary care are not in the academic setting. And so kind of wanted to say, okay, what is it like there outside of the setting to practice? So that's where I found myself after my training. It was my first job as in an organization that was a very large organization, which multiple offices spanning, 50 to 100 miles. They owned several hospitals in the region as well. And so that's where I was working, and I was kind of on that journey figuring, and then starting to hit kind of a wall at a certain point. And I was doing hospitalist work as well, doing per diem hospital work at one of the hospitals that was owned by the organization that I was working for, as well as the full-time primary care. So, partly because I do love hospital work. I love the intensity of it. And we got to cover some ICU care. And so I just didn't want to give up some of that skill set that I had, been working hard in residency to establish. So I was doing per diem, and I would cross paths with Dr. Vasquez Bryan, who was Jennifer Vasquez Bryan, who's family medicine doctor. And she was getting her own DPC off the ground. And so she would make comments about it. And I honestly don't think I really quite understood what she was saying when we even talked, just kind of knowing that she was kind of doing something interesting, but not really knowing the details of it. And so working in the job where I was, it was an amazing opportunity. I felt like so, bright-eyed, bushy-tailed coming out of residency, ready to be a primary care doctor, like the primary care doctor. And I was happy about the position that I was in, where it was the first time they had a pediatrician kind of in their system. It was always, the pediatrics were sort of, smaller practices in the community. So they hadn't really had a pediatrician in their system. So I sort of felt like I was able to take on that as like, okay, I'm the first pediatrician, I'm going to help with the workflow of some stuff, and got to start a practice from scratch. So I didn't walk into a patient panel. So I was able to bring a patient panel up the way that I kind of wanted to. So got some word of mouth too, as a new doctor, as a female doctor, which many people kind of look for specifically. So it was exciting, but there was, probably within a year and a half, a switch of realizing that what the momentum that I came with was starting to slow down, and I was starting to feel very, very tired and very overworked and underappreciated. I loved all my patients, but I started to realize from a system level that primary care, I had this idea of primary care being so important, but that primary care was not and would not be anytime soon a very respected specialty in the system that warranted, the financial and administrative and manpower support that it really deserved. And that change was trying to happen. And I was involved in some of the committees and some of the ways to talk about these innovative, quote unquote, programs through CMS or through other things that try to, realign incentives and things. But these changes were so small and they were happening so slow, and the implementation was so painful that I just saw that I just couldn't see this being sustainable for my goals. Not to mention the work-life balance that was sort of really starting to falter. So this is a long answer to how I found DPC, but I do remember a moment when I was emotionally pretty drained, and I came upon a video that was by ZDogg MD that highlighted the moral injury terminology. This was probably sometime in 2018. And that, I think the timing of when I saw the video and probably what was happening contextually really hit home. And putting a terminology to that of what I was feeling is sort of, when I heard that and heard him explain that, I said, whoa, this is a thing. And what's happening, what I'm feeling right now actually is like a concept. And so once I started to connect those dots, that was in 2018, after I had been working for about 2 years in the system, I started to realize, well, how am I going to get out of this? What is the next step? And so lots of different things crossed my mind of doing, just saying, all right, well, if primary care isn't ready to really go to a place that I wanted to go, maybe I need to do something else, be a hospitalist for a while, or maybe go just do pediatrics for a while, which is a little tiny bit more insulated. Or do something else. And it was sad to even have to think about it, because I think naively I was imagining maybe I'll stay at this first job forever, which I think was naive. So talking with Dr. Jennifer Vasquez Bryan, who was, kind of a colleague, I started to talk more specifically about DPC and said, hey, let's get more details, and kind of more excited about what she might be doing. And so she started the DPC called Altucare Primary Medical Care in 2016. And so over the couples of years that I was working in the more insurance driven system, she was building her practice. So finally we came together, and this was probably around September of 2018, and met in person with her at her house with her husband and her kids and my husband and my daughter as well. And they really explained DPC, why it was so great, sort of, how it worked, what, kind of introducing me to it. And then I thought we were kind of going to go down the path of, all right, well, let's join forces. I know at one point was hoping to grow with another doctor and have 2 doctors, but there was sort of a twist to the story when I met with her, that she and her family, for their own personal reasons, decided they wanted to relocate their family. They were living in New York and decided they wanted to move back to the West Coast, to Washington State. And so I was like, oh, okay. So then what's going to happen to this amazing practice you just told me about? And they're like, well, we were wondering if you might want to take it over. And I was like, well, okay, this is kind of a lot to take in. So, I remember driving home with my husband, and it was probably almost an hour drive from where we lived to from where she lived, and talking and just saying, I kind of said, how could you not do this? It's almost like you can't unknow the situation of DPC at that point. It's like to know that that exists, or that's an opportunity. And not only is it an opportunity that's out there, but an opportunity that you could do soon. Like, how could you not do it? And then there's just, and I think, so conversation with my husband and I, and then going back to Jennifer, and asking some follow-up questions, and then figuring out timing, like, you want to move, like, when were you thinking? And it was kind of like, no, we'd like to move actually probably early next year. And we probably want a decision from you within a month or two, a couple of months. So it wasn't really a question to join DPC and start to find that journey, but it was like, do you want to buy and take over and take on this practice? And so that was in around September 2018, where we kind of had our initial meetings, and I learned more about DPC. And basically by November, made the decision that, like, I know I have a lot more to learn, a lot more to think about, and some details to work out. But I think I'm going to go ahead and just say yes. And so I gave notice to my work. And so where I was working, and the notice we have to give was 4 months. So it was like, you have this moment of like, yes, I'm leaving in 4 months. Great. So that was in November. And so I worked, those 4 months I remember were very busy. It wasn't like you slow down the pace of what you're doing, even though you've given your notice. So you're still seeing all the patients. And then there's the awkward thing, at least in the kind of corporate medical setting, where you can't really tell them what you're doing or where you're going or what you're doing. You just kind of have to say, you can't really say anything. They don't want you to say anything to your patients. So kind of that awkward. And then basically gave my notice. And then in April, joined Dr. Vasquez, Brian, and had a couple months of transition. And then she and her family relocated July 1st, 2019. And DPC kind of just was there. I was just in it. And so I was kind of playing a little bit of catch up with DPC after I already became a DPC doctor, which is kind of strange. So there was definitely a lot of like imposter syndrome at the beginning, because it all kind of happened fairly quickly. And I guess in retrospect, I'm telling the story now, there was a sense of desperation, I think, because I realized there was not a sustainability to what I was doing. But at the same time, there was a clear just aligning of the stars of like, this is an amazing opportunity. And I trusted, I knew Jen from various interactions, and through our times together and conversations, I really did trust her. So I didn't feel like I had to vet every single thing of what she did to make her practice. I knew that what she had done was very pure and very DPC, because she was so passionate about it. So that's sort of how I found DPC, is more that DPC found me and I just kind of jumped into it.
I'm a very, very big believer. I've said this so many times, but I will say it again and again. Things happen for a reason, right? And thank goodness that, you were at a point in your life where you could appreciate this opportunity that presented itself to you, and that you were able to embrace it. When you gave your 4-month notice, did you have an issue with a non-compete? Did you have an issue with non-competes at all? Or what's the environment like?
Yeah, no, the environment is very non-compete heavy. In fact, one of the sad things I saw early on when I first joined, I sort of joined as a, right out of residency, here's your pretty standard contract. It's going to have a non-compete on it. We are basically told for most of these contracts from large organizations are all going to have a non-compete. So, you can maybe squabble a little bit about the distance or the time, but it's going to be something. And but when I got to the organization where I joined, one of the first things that they did in the first half year that I was there was try to roll out this generic contract for all these old school docs who had been sort of acquired over the years from the community and didn't really have non-competes, and were sort of to be like, all right, everyone's going to have a non-compete now. So just seeing all of that transpire in the system of like non-compete, I mean, it just, for primary care, it just seems insane really. And it's just really a detriment to the patients at the end of the day. So yes, I had a non-compete. We won't go into that digression too much. So yes, I had a non-compete. It was 15 miles for 2 years. And actually my 2 years is coming up. And the practice that Dr. Vasquez Bryan had was outside of that already in a town called Middletown, which is in the Hudson Valley. And it was about an hour away from where my practice was and where I live. So the non-compete did not have to really be factored in as far as whether the practice, had to be moved or something like that. But it did factor into just, making sure that it was within the distance. And I guess we'll get to the whole transition part. But what ended up happening is when the transition started to become, more firmed up over those 4 months, the landlord of where Jennifer's practice was basically was like, there's a lot of changes happening. Like they were on a month-to-month lease. And so they said, well, we're not going to renew your lease anymore. So in the middle of that kind of transition 4 months, we also found out we were going to have to move the practice to another location. So that did factor in. Now, wouldn't it have been great to be able to move it closer to where I live? But I did have a non-compete, not to mention many of the patients, I probably would have been lost had we moved too far. But we did move, and we did move half hour away from where the previous practice was. But it was still outside of my non-compete distance.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. It's devastating for patients because when there is a lack of primary care and a push for primary care being taken over by people who are not physicians, it's really disheartening to know that is what patients are dealing with and what patients are unaware that they're dealing with. Right. As a family medicine doctor, it pains me to see the ratios of numbers of patients ballooning compared to the number of physicians who are practicing primary care. And I'm glad that it worked out for you in terms of, where you lived and where you were practicing worked out with that non-compete. But yeah, it is another way that the insurance-driven healthcare system really takes away from the doctor-patient relationship.
Definitely. I mean, it not only takes away from it, it completely doesn't respect it. I mean, if it had any respect for the relationship, it wouldn't have a non-compete that would basically sever the relationship simply because of a work decision. So yeah, a total agreement there.
Yeah. Talking about the transition, it's really interesting because it's not too common that a DPC doctor has worked and then taken over a practice of a previous DPC physician, especially in this time. I think that that's going to be way more common as DPC continues to grow and succeed in the future. But with your transition, how was that with regards to patient reception, with regards to the nuts and bolts of your practice? How did that go for you?
Yeah, no, and I think you're right also that I hope actually it will be more common. And I actually, to be honest, would encourage anyone who is starting a DPC, not necessarily to have an exit strategy by any means, but to think about life happens and to think about if what you're making is transferable, because I think there's an amazing part of making the practice your own, which Jen certainly did in her ways. But at the same time, it didn't completely define the practice such that it couldn't even run without her. So I think she had done a great job, I think, of bringing a lot of her, herself to the practice. And they came up with the name, they came up with the logo. And I also really respected all the time and energy that they put into that. So I had no intentions of really changing it. I mean, I think they asked, what do you think you'll change? And I was sort of, why would I change? I mean, what you've built so far is so great. And there's no point really to change much of the foundation. And so, and again, I really had such respect for Jen and her husband, Eric, what they did, because I told them several times that I'm not sure I would have had the guts myself to do it from the beginning. And so to be able to take all of their I'm sure they spent hours conversing about all the different details of how to make the practice function the way it was already functioning. So those really what it came down to was almost a training period for me, is how have you structured it and how can I maintain what the structure you've put in? I'm not going to second guess a bunch of things right now. So a lot of it was time spent together learning the medical record system and how they do what the billing system is, how they do faxes, how they do the phones, how they do emails, or how they do the newsletter, how they manage other kind of data on the back end. And so a lot of it was kind of almost a training, on the job training. And then as far as how it was expressed to patients. So Jen had notified them, I think around the February timeframe. So putting in context, like I didn't start there till April, but I had already given my notice by November. So by around the February timeframe, I think she kind of notified the patients in a newsletter about her and her family's desire to relocate. But, there was another doctor coming in to take over. And so was able to introduce me that way and what my training was and background and things. And then we did have a couple of open houses at the practice where if patients wanted to come and meet me and talk, we could do that. And so that there were a handful of people that would come and do that for those couple of times. And I don't think either Jen or I really knew what to expect as far as patient adoption of both the change in the actual practice location and the change in the doctor. And I think it was sort of a question of like how much of DPC is related to the doctor, him or herself, and how much is DPC is related to the model itself. And I think it's a mixture, but we were happy with, at least at the beginning, that most people did not quit. Most people did not cancel. Most people did stay. So the transition really was about 3 months of me. So I would, at the early beginning, I remember Jen would even see patients. I might even be in the office, but I was like so overwhelmed with trying to like understand the system. I had to get my own malpractice. I was like, wait, I have to do all this other stuff too. So kind of just trying to wrap my head around all of it. So even the first couple of weeks, I think I wasn't even really seeing patients with her. I was just kind of waving at them as they came by, and then slowly start to see them together. So I might sit in on the patient visits with her, or maybe she would give me a little heads up on them before they came in, and then maybe I would just kind of see them at the end. But then as time went on, we would really be seeing patients together, and then especially once we moved the practice, which was in May. So I kind of joined in April and started to get my feet wet. And then we like physical manual labor between her, me, my husband, and her husband, moving, exam tables and furniture and everything with a trailer and a truck. You're like, wow, this is quite a doctoring experience. It was actually pleasant memories to look back on now of just the journey we did together. But so once we were in the new location, and it sort of started, I guess, feel even more like mine by that point, because Jen had no intention of practicing in that location anyway. So it was really transferring everything to me. Then I would start to see the patient. She would be there too. I would do more of the note writing. and refills, and even Jen would start to maybe push some tasks to me saying, so and so requested a refill, can you refill it? And again, I have to give Jen so much credit for just really welcoming me and so patiently, I think, to the process. And I think just I think it was a right fit too. We had very similar, I think, values as far as primary care and how we wanted to care for our patients too. So again, it worked out, but there is a transfer. So anyone who's transitioning from practice, I mean, I think there are probably good ways to do it and not good ways. And I do think we somehow managed to do it well, which was a kind of a combination of training on the back end stuff for me, and then like mutual patient visits together.
It's interesting because, as people are creating their own practices and blood, sweat, and tears are put into these
Mm-hmm.
practices, it is so incredible that it worked out that you guys knew each other beforehand. You weren't questioning everything. You weren't vetting her, as you put it. You didn't need to because you knew her from beforehand. But it is so interesting that the process went, so smoothly for you. When you look back, especially for future advice for people who might be undergoing this transition with others in the future, what advice could you give somebody in terms of what could help another practice make a smooth transition? If there's another doctor taking over or buying the practice or even adding a new doctor?
Mm-hmm. Yeah, I mean, I think really getting all both on the same page about sort of, and having good communication. I think there was some back and forth, or Jen would check in and say like, is that do you feel comfortable with that? Do you not feel comfortable with that? And so I think just having that openness about the transition, um, and I think also just a general patience, just for the fact that two people do things differently, and so you're going to have some understanding that you have to let things go too. Like a transition is not the time to start trying to flex your muscles, kind of. I think a transition is a time to make it go smoothly. So kind of to, if anyone's doing a transition, to kind of have that as the priority, is to have it go smoothly. And so that may mean making concessions, or sort of knowing maybe you'll do some things differently, or maybe knowing that you'll make some changes in the future. But the transition time is not usually the time, I think, to do that, and to really think about the patient experience, and to keep focused on that, of like, how do you keep the patient care smooth first, and then how do you make yourself integrated into the practice second.
I love how you say that, though, because when we look at direct primary care from the business perspective, from the entrepreneurship perspective, if we don't have patients, we don't have a practice. So I love that you mention, keeping the patients in mind, because I think that anybody who is even considering starting a practice, or who has started a practice already, they can easily envision that mentality of, what would it be like to a patient if I did this? So
Right.
I'm really
Yes.
glad that you mentioned that.
Yeah, and I think that's where, you get the questions of, well, do you change the phone system? Do you change the medical record system? Do you change this? And all of those there might be subtle reasons why you might think about doing that, but then making too many changes at once, and then how are you going to disseminate all that information? Okay, here's your new portal, our new phone number, here's our new way of doing things. I think I felt also with the transition, again, part of it was this a little bit of this imposter syndrome, where I hadn't quite walked the walk of DPC from the beginning either. And so did not have any of the confidence to start even having these strong opinions really about anything. And I think having that humility to just kind of say, that I'm going to just kind of go with what you've put your blood, sweat, and tears into, and then it'll unfold, and kind of trusting that the fact that there's always opportunities to make adjustments in the future. It just, the transition time, it doesn't have to be that only window of time where you can reconsider things. And I think also, because we had mutual trust for one another, and were more, on much more familiar terms, I would say our legal transition was much more loose than maybe other people might want to do, or even would advise to do. But it worked out for us, and we sort of got all our I's and T's dotted, but didn't feel like we had to necessarily bring in, the top tier team of lawyers to make it all happen.
Did you guys have two separate lawyers look at the practice and individually come up with a way to transition you guys? Or did Jen's lawyer primarily do all of the paperwork and it was just reviewed by your lawyer? How did that work?
The transition wasn't really understood from the legal standpoint in the ways that we wanted it to, I guess. And so there was a little potentially more risk, I would say, if the lawyers put it in their terms, more risk in the way we did it, which is basically I took over. I didn't close up her shop and open mine. I joined her and then she left. So that's the way we decided to do it. For one, it was from a paperwork standpoint, made it easier for us from a PLLC business standpoint. And yes, there might have been a more amount of risk involved in that from a legal standpoint, but that's how we decided to do it.
When you did transition and you were practicing at Altucare on your own, what was your patient load like, and how did you were describing that there was some transition where you were slowly going into the visits with Jen, but when you were fully on your own, how was that transition to get everybody seen, quote unquote?
Yeah, so it was it's hard to even remember back then, but we got a lot of people seen in those few months together. And then there were certainly people that took me a long time to ever even meet in person. And a lot of it was just kind of trying to learn the system on how to engage with people, send them messages, and kind of pick up on their appointments already scheduled, on the schedule later, and then people, calling with inquiries wanting to get scheduled. So once I was on my own, it was just kind of like trying to focus on who needs what, answer the messages, answer the appointments, make the appointments, meet the people, and really kind of just focus on that. And then really most people did get seen over those several months, at least after I was on my own. Within a few months, most of the people had at least been seen, I think. And my patient load, I mean, I took over the practice somewhere in the 150-ish range. There was some turnover, a handful. I mean, I'd say over the July, August, May, June, July, August period, there might have been a 25 at least people leaving. But then when I kind of joined Altucare, some of my old patients, or my patients, they're not all old, but all my patients from my previous practice that was 45 minutes away, some of them wanted to still follow me. And so there was also an influx of people at the same time. So I sort of got quickly good or experienced, I would say, at onboarding people. So knowing, what has to get done when you first have a new patient, the patient agreement and the questionnaires and things that you want to do, and rolling that out several times, repetitively over those few months too. And then, so I kind of started off the practice in that way, where there was some turnover, not a ton, but also the turnover helped me get experience at sort of the comings and goings and how all of things worked and stuff. So yeah, the patient load was definitely way less in the sense of what the number of people getting seen per day than what I would have been seeing in my previous practice. But there was a lot more sort of other learning and other things that I was trying to keep track of as well.
Since you have taken over fully, have you been able to take vacation, and what do you do for coverage if you do take vacation, given that you are a solo practitioner?
So it's a great question. So, when I first took over, it was July 2019, and, didn't have many plans to take vacation. I think we did do a brief vacation, still in New York State, but it's like, 6 or 8 hours away. And that worked out okay. I gave patients advance notice that I was going to be out of town, but it was just like a weekend. So I actually don't really have coverage firmed up as far as vacations, because not too long after that there was coronavirus pandemic, and then really just kind of all staying local anyway. So to be honest, I haven't experimented with coverage, although there is actually a couple other DPC practices in the region, in the Hudson Valley region, that I think would have opportunities to just work it out. We just haven't, really had the need to hash out sort of a coverage workflow.
Now that you have been in Altucare over a year as a sole practitioner, how have you made it your own?
So it's a good question, and I think I'm probably only at the beginning stages of really making it my own. I think a lot of my time and energy initially was spent kind of learning about DPC backwards. So, I didn't have a lot of, the readings under my belt, or even just the history of DPC under my belt by the time I had a DPC practice. And so some of it was my time was spent really focusing on the patients, understanding the workflow, what has to get done as far as what bills had to get paid, how to order supplies, how to engage with vendors, getting set up, making sure that the things that were set up were still set up, especially since we moved. And so a lot of it was sort of like, you don't really know something's either working or not working until you kind of have to do it or use it. And so it kind of had to go through a few cycles of things before I could really even think about trying to make anything completely my own. I had the way that I practice medicine, which I was able to implement quickly, right away. But as far as how to make that, C1 DPC, C1 DPC, like how is it my DPC kind of thing, I think is only just beginning. I started engaging in Instagram about 6 or 7 months ago during the quarantine, and because there wasn't really a big social media presence for the practice. And so starting to have that, and then starting to sort of, part of it is a self-discovery thing of like, wow, I don't really have these ties or these shackles anymore of what I should be doing. So now I get to actually think about, what do I want to do? And I'm not sure I even knew all the answers to that. So then there's time taken to kind of figure that out. And I do have an interest in sort of mindfulness and meditation. And so starting to engage in the local community and things that I was interested in. There's a large art net, being close to New York City, there's a lot of like museums and art stuff and music. And actually, near where I live is Woodstock, New York. It is the Woodstock in the sense that, there's lots of hippies and lots of tie-dye there, but it's actually not the actual site where this concert happened, but that concert was not too far away. And so there's a really cool community. So starting to understand, I'm in the community now. What are my interests? How can I bring my interest into the practice a little bit more, my personality into the practice? I love music. I'm a musician. I play violin. Since I was little. And so starting to actually conjure up some of these old interests and passions, and realize that they actually might be able to meet somewhere with my medical interests too. And so I invite my patients every Friday to join me in a meditation that I attend that's sponsored by a local kind of nonprofit art organization, and connect with them on ways you can go outside to walk on the trails. There's trails all over the Hudson Valley, because that's what my family and we like to do. And I don't actually run the Friday meditation. It's a community that puts it on since COVID. And so I sort of join them and then invite my patients to come, and actually it's this really awesome organization that has their kind of mission is trading the art of medicine for the medicine of art. And basically all these artists and these medicine and these doctors and providers, wellness providers, like get together and give free care. And then you get art and all this stuff. So it's really cool. So starting to make it my own as far as, what do I do? What kind of stuff do I like? How do they get to know my personality? And how can that then affect, their well-being, or how we can engage together? So I'd say I'm at the beginning stages of really making it my own, as I've kind of worked backwards about learning about DPC, and now finally, taking the next steps to make it my own.
With you sharing how you are a musician, and with you now building in that uniqueness to your practice of having these meditative groups and incorporating that into your Fridays, has that also just fed your soul with regards to treating yourself as a person and allowing you to continue in your position?
Definitely. I mean, I think there wasn't any room in my cup, so to speak, for any of that when trying to focus really on the other way of practicing, driven by insurance companies and volume and things, that I felt like the only choice I had was to silo myself from either work or not work. And so it was less comfortable to necessarily share personal things, and no time really to share personal things or engage people in sort of maybe interests that I was exploring, that if I explore could share. And so there's just so much more richness that can come from the relationship if there can be time to both search yourself on what feeds you, and then not even if it's not the same thing that is going to feed somebody else, but to recognize that that feeding is important, so to then encourage it for other people. And I think it's very hard to genuinely do that when you're not there quite, you're so far away from that yourself. So I'm not by any means really where I actually took out so I have an electric violin and that I mostly use because it's sort of easier. I don't have to worry about breaking it or something. But I recently took out my acoustic, violin that I've had since high school. And I was almost dreaded opening up, thinking like, what am I going to see when it's been over probably a year and a half since I've opened it? And what am I going to see? Am I going to see it like eaten by bugs or something? Or I don't even know. So, but I opened it and it was just like, this was only a few weeks ago, and I was just so happy to do that. And I don't know if I even would have got to that moment had I not been able to just start feeling like I could find parts of myself, and then be able to practice medicine at the same time. It was sort of felt like it was one or the other. And so certainly being able to share with people, whether they're the same interest or not, but just acknowledging the fact that having interest is important, I think has really helped making the practice my own, and then providing even the medical care that I, am able to provide.
Building on that, how has being in that position overflowed into your family life?
So I think there's a lot more flexibility in the family. I think, there is and was like a dream of sort of not so much distraction and being pulled into the medical field as often, and like having interrupted moments with the family. And I think there was a point where I thought, well, maybe I could really get rid of those completely. But I don't think those are going to get rid of completely, no matter what system you're in, really. And so I won't say that like I'm not going to paint a picture of like I'm totally, with my family, I get to like do all these great things and I can just forget about the practice. And that's not the case. But what it is so much more flexibility and just back and forth and tweaking of things that you don't have to worry like, here's the one time I get to shift my schedule and tweak it. I hope it's the right move, and I'll try to make another move in 6 months if I can, kind of thing. Where there's a lot more, you can kind of, it's almost like in clinical settings when you're doing like your quality improvement project, where you're like, here's a tiny change, and then you get to study it again and make another small change and build on it. It's a lot more of this like that quality improvement on a micro scale that's able to happen in this kind of model because of the ability to have your interests and medical and all just kind of all in the same pot together.
The fact that you are a sole practitioner, how are you handling after hours care?
After hours care, I mean, it's a learning process. Part of it is sort of teaching patients sort of where the boundaries are. Part of it is deciding what the boundaries are. Part of it is, deciding what my personal either strengths or weaknesses when it comes to managing boundaries are. So I say, I think people do sometimes in fact, I did a presentation, I think for some local Rotary or something. And somebody asked the question of like, well, if you're available all the time, aren't you getting calls just like all the time? And the reality of it is when you have a good, strong relationship with a patient, there's a mutual respect there. And once you have mutual respect, then the idea of picking up the phone at 11 o'clock at night because you have a small problem, but you have mutual respect for the person you're calling, the patient may make a little bit of a different decision. So there's sort of that learning process and the relationship building that then leads to after hours, how that's going to manifest after hour calls. So reality, I mean, I take all the calls. I don't roll it over to anything, and I try to make it so that if someone did call me in the middle of the night, that my phone would ring and that I would be able to get it. And sometimes there are calls that come in. I think this morning a call came in while I was trying to get my daughter ready to go to school, and you have to kind of take it. And but so there are challenges, but again, I think it all goes back to building that relationship and then having that mutual respect, and then that will lead to a situation where most of the after hour stuff is going to be mostly necessary.
In your practice, do you have any tech or tools that you use or love that you would like to share about?
Yeah, so a few things come to mind. So we do use the Google Suite, and I do feel like that is a nice integrative software that brings in like email and phone and the text message on Hangouts, and now with the video even too, although I haven't used that too much. So that's a good option. I actually like using it, and it's also familiar because if you use Google in other personal ways, you're kind of familiar with it. So yeah, that. And then I was introduced to something called KeyPass, actually by Jen and her husband, and have found it invaluable. It's basically a way to keep track of your passwords. I hesitated to say that that's a big resource for me, but I think whether it's KeyPass or something else, I'm sure there's other things out there. But one thing I've noticed with all the accounts and all these things to keep track of your logins and passwords and all this stuff, I felt like that was a huge help in just making things easy. And then and Jen, so she speaks fluent Spanish actually, and so some of her patients were primarily Spanish speaking. And so when I transitioned, I had to I do have some Spanish background, and actually patients do appreciate us trying to converse, but I felt like going in that I wasn't sure how it was going to work out. So I did look into translation services so that I could have them available. And I found one called JR Language, and they're based actually up in near Rochester, New York, actually, but they're all over the world. And what was really nice about them is so many of these language companies that you want a live person to try to do the translation, since that's what you're kind of trained to prioritize if you can. And they didn't have any minimum amount that you had to use per month or any fee. It was just a one-time setup fee, and then you can use it. And also it's not just Spanish, it's like all the languages. So I would definitely encourage anyone who's like thinking they want to have a translation person-to-person service in their back pocket to check them out.
And is JR Language a subscription company, or is it per translation?
No, so that's what's so nice is you don't have to do a subscription. It's just for the minutes on the translation. So, and most of them I found were somewhere in the $2 to $2.50 per minute range, which sounds like a lot, and it kind of is. But what at least is nice is that there's no minimum. So some of the places will say, well, you have a minimum amount of minutes regardless of whether you use it, per month that you have to pay. So this is just a one-time setup fee, which I think was like $150 or so, just to kind of get the phone number and the passcode basically to use when you need it. And then there's no minimum. So I don't think I've even used it in a year. I actually used it for somebody who spoke primary Italian, and I felt like I needed to speak directly to that patient without their son translating. And so I found it helpful and very easy to use for that. And you just get a bill for however long that call was. The next invoice will just be for however many minutes you used, and then that's it.
And Catherine, do you know if they are limited to, because you said they have multiple locations, is that all over, is that accessible anywhere in the United States?
Yeah. It's just like kind of like the blue phones in the hospital, where you just call a number, You put in a code, and I don't even know where the person is that is answering or doing it, but I'm sure they're pooling from a whole bunch of places all over the world, and then someone kind of takes the call and does the translation.
That's pretty incredible, especially, with with the DPC model, we're always trying to maintain quality but keeping down cost. And so that's great that you found a resource that doesn't require a minimum amount of minutes for translation. You've shared, about your transition and how that went for you, and you've given advice for people who are potentially seeking a transition in the future. For those people who are finding out about DPC from like resources, like you mentioned, like books and lectures and whatnot, given that you feel that DPC found you, what advice could you give someone who's entering the DPC space?
Well, I think my advice would be that to think about the long game for your life and for your career, and see DPC as a potential investment in that. And that's sort of where I came from. And I think whether it was jumping in a transition or jumping in new, I think there's risk in both of those things, but that you have to think about the long game. And that's also how I feel about patient care. Is primary care is the long game also, and not the short game of get things controlled in a couple of months. It's the long game of get things controlled, get them uncontrolled, get them controlled again, get them, it's the relationship over time. So the same for DPC. I think it's the long game, and it really might be a fit in that context.
Very well said. And on that note, what is the best way for others to reach out to you if they want to connect after this podcast?
So people are welcome to email me directly at cagricola@altucare.com. You can also find me on Instagram at altucare.md. There is a Facebook page as well, so people can message to that if preferred. You can also call the office. Probably email is the most direct way to reach out to me.
Thank you so much, Dr. Agricola, for joining us today.
Thank you so much, Mariel. It was really a pleasure, and just thank you for everything you're doing.
Next week, look forward to hearing from Dr. Bhavna Rao and Sunil Vasisht of Meridian Springs Primary Care. If you like what you heard today, please leave a review and subscribe wherever you listen to your podcasts. Tell your friends too. For more information on this episode and much more, please visit mydpcstory.com. Also, for the latest in DPC news, check out dpcnews.com. Until next week, this is Marielle Consumption.